For the sake of time, we will go ahead with the final presentation. طبعا Prince Sultan Center نحن as a GIS we always respect and يعني the history is glamoring. So complication of left main intervention by Dr. Imad Sheiban from Italy. Most welcome. He is a friend of the GIS and go ahead.
Thank you very much. Good morning to everybody. So possible complication in left main interventions are left main dissection, aortic dissection, thrombosis, perforation, stent or balloon embolization, deformation or rupture of the stent, cardiogenic shock, abrupt vesic closure, or side branch occlusion, or stroke. So mostly is iatrogenic dissection caused by guiding catheter. And I think if you or still already having wire inside the true lumen, this is a easy situation, correct? Otherwise, if it is without any wire, then this can be much more challenging and actually should be taken in consideration very carefully, wiring and stenting to correct this situation. In aortic dissection can happen at any osteal lesion or by guiding catheter sometime or by predilatation. When it happens, stop injection, place a stent to seal the entry point. If it is extensive dissection, then surgeon should be consulted. Coronary thrombosis, this might happen as iatrogenic, that means thrombus injected from the guiding catheter, or by thrombus formation in situ because of suboptimal antithrombotic therapy or disturbed hemorrhagicity from intracoronary instruments, accidental thrombosis migration from one vessel to another during aspiration or thrombectomy. So again, in these cases, thrombus aspiration is needed, as well as antithrombotic therapy in situ or systemic, balloon inflation or agitation before may disperse small thrombi causing distal vessel occlusion, but again, antithrombotic therapy might help. Stent thrombosis in distal left main, protruding struts like metallic carina, bulky metallic carina can cause the formation of stent, like in this case, as you can see reported, and you can see clearly the protrusion of struts, uncovered struts in left main, which might cause the thrombosis. Sometimes it happens also in very simple situation like provisional stenting. This might be due to underexpansion of the stent because inadequate lesion preparation, as in this case, and this again, thrombus aspiration, as well as post-dilatation, and it is also recommended to check with intracoronary imaging. Now, perforation, it depends on the site of perforation, whether it's on the shaft or this can be easily treated by covered stent. Of course, if it happens at the bifurcation site, then this might be more challenging because the use of covered stent will lead to the occlusion of one of the two branches. And actually, there are more and more cases reported in literature using the covered stent also in distal location of perforation, sometimes with some creative approach, like in this case, using the covered stent, and beside the covered stent, also a balloon in order to keep flow to the side branch. So simultaneously putting the stent, the covered stent toward one, the most important vessel, and the balloon for the second branch in order to keep the flow. But actually more and more cases also reported with the possibility of fenestration of covered stent. That means use of covered stent and then fenestration of the covered stent where the lost side branch. And in these cases, it's highly recommended to keep a wire in the occluded branch in order to guide you where to fenestrate the covered stent. Now, these large stent retrievements, we have many snare devices and also that twisted wire technique for retrieval of this large stent, as well as balloon fixation technique for the retrieval of stent dislodgement into the aorta. That means inflating the balloon distally the stent, but require that the stent should be already on the wire and then to retrieve the whole system. And stent deformation, which might happen both by crossing with under expansion of the stent and recrossing beside the stent, and then this will be deforming the stent as well as retrieving devices from the stented segment might give an elongation of stent and deformation, and this might be corrected sometime with another stent placement to cover the deformed one. Now, cardiogenic shock, like in this case with diffuse disease on distal left main with chronic total occlusion of LAD, chronic total occlusion of right coronary artery with dominant circumflex, and can see here what happened just wiring the vessel, the three vessels. You can see what happened with the patient. So I think in these cases, the device, the issues are mechanical circulatory support, which and when, and only culprit lesion versus complete revascularization in the same sitting. But I think that before proceeding is much better to have mechanical circulatory support, as well as to limit the treatment for only culprit lesion and then completed later. Make it easy as much as possible. So use whatever you are more familiar with and do it very quickly. And I think if you have another expert operator beside you to take care for other aspects of hemodynamic stability of the patient, will give more and more chance to success in this procedure. In this case, we did what we have planned, that being only culprit, that circumflex and distal left main, and then after 4 days, the procedure was completed by recanalization of LAD and right coronary artery, and this patient was already at 26 months follow-up, event-free. If you have a patient like this arriving in your cath lab for STEMI complicated cardiac arrest, a patient resuscitated and intubated in emergency room and transferred to cath lab in cardiogenic shock, I think the most important thing is start with impeller positioning, implantation immediately, and then start to wire and to do whatever it's needed to stabilize the patient. And again, here in this patient, impeller gives us the possibility to make a quick and fast distal left main bifurcation with mini culotte stenting. And this was the final result. And after 24 hours, you can see the dramatic change in electrocardiogram, and the patient left with 0.45 ejection fraction, means that he had a good chance to survive longer. And again, finally, abrupt closure we have described before, as well as stroke during left main rota or thrombus aspiration might happen during the procedure. So this is the table summarizing the complication, the possible cause, and the management, as we have mentioned before. And my final remarks are, at some time or another, interventionalists will be confronted with procedure complication. First rule is to try to prevent complication. That means plan your procedure, checklist with your team, discuss the case, and be open to listen to any suggestion from your team. Until patient is stable, don't panic, watch carefully, evaluate the most convenient, easy, and safe strategy for the patient and for the operator as well. And lift main PCI complication management requires preparation, early recognition, and broad differential diagnosis, knowledge of effective techniques, and team-based work and strategies. Lift main complications are always high risk for complex procedures. Key of successful management is to have optimally equipped cath lab, good experience both operator and cath lab team in complex interventions and emergency, because this kind of procedure is not single operator procedure, but team procedure. Thank you very much for your attention.
Thank you very much, Dr. Imad. For the sake of time, I would like just to thank you, and we'll move, and we're trying to close the session. So we're going to cancel the questions and answers. Hopefully we have other sessions we can discuss it. I think we had a very good session. Sorry for the time limitation, but we actually went through the different difficult anatomy, and we discussed about PCI and cabbage, and also we explored all the tips and tricks that comes with lift main intervention. We had a great complication session as well. I would like to thank you all and thank the panelists, and I'm sorry if we had a very limited discussion, but we are really behind schedule and we have live transmission, and we are forced to do this. I appreciate your understanding. Have a good day. We're going next, please.